Since there are some new people in the room, we've talked a lot about CaPP2. So CaPP2 is a clinical trial we set up in the 1990s. It ran through to 2020. And I need to update Kevin's slide because he's still using the 2011 graph. And the 2020 graph is much better. So that's the one at the top. So that shows that over 20 years, basically, it keeps on getting better, even though we only treated for the first 4. And also, we talked a little bit about resistant starch. So the people who were given resistant starch supplements to their diet for 4 years had a dramatic impact on their non-colorectal cancers, in particular the upper GI cancers. So in the placebo group, there were 21 upper GI cancers, and in the treatment group, there were 5. So there was a 75% reduction in upper GI cancers. It took us a long time to get that published because it was almost unbelievable, but it was exactly the same double-blind randomized controlled trial. And we think it was probably something about changing the microbiome that had a long-term impact on the upper GI tract and the secondary bile acid production. But whatever the explanation, eat a green banana, and I foolishly posed for a photograph out there with Kevin holding a tray of green bananas, which will be used against me forevermore. I was asked to briefly update on CaPP3. CaPP3 finishes in June, and this is Robin. Robin was our last patient, last visit in Newcastle, and so he has now finished his 5 years of treatment. I went to see Nick last week. Linda and I were out at his workshop. He makes furniture, and he's been working on the sycamore gap tree, in fact, and he's going fine. He's been on his tablets now for 10 years. So basically, we randomized 1,879 people, 1,500 of whom were in the UK, and they took 1 of 3 doses, blind for 2 years. Then we opened labeled it so that it wasn't quite so expensive. And many of you in the room, I know, have been on this. Thank you all for your continued support of this. So basically, once we get to 5 years, then we can look in the box and see how many cancers have occurred in those 3 groups. To answer the boring but necessary question, can you get by on less aspirin and get less side effect risk as a result of that? Can't tell you the answer yet, but we'll have it as soon as we can. And it's all down to the NDRS as well, giving us the information we need on the cancers. Well done, yes. And also, of course, Lucy and Catherine, the guys working with Claire Turnbull, have helped us enormously, because everyone in CaPP3 is consented for long-term follow-up through NDRS and through the Lynch registry. So we'll be able to carry on tracking this at relatively low cost to see whether the 1,500 people who took part in this are doing better than the people who were not in the trial. And as you heard from Kevin, many of whom are still not taking aspirin. Okay, so the reason I wanted to talk this afternoon, or we want to talk, was about urine testing. And you've already had a preface to this from Neil. So urothelial cancers, this graph you've seen a few times. So this is the proportion of this type of cancer that is associated with Lynch. So you heard about sebaceous tumours from Neil and Georgie, and clearly a huge proportion of sebaceous cancers are Lynch syndrome. So basically, we're arguing we should probably just go straight to germline testing. We should go straight to germline testing in that group. In the other cancers, it's colorectal and endometrial. Urothelial is number 3 there, and it is the 3rd most common that we see. Now, this is about urothelial cancers in general. So the term urothelial is a bit vague, but it's basically the sort of lining of the urinary tract. And bladder cancers, of course, are relatively common in the general population, often in older populations, and a relatively small proportion of those will be Lynch. Whereas in the upper tract, we think maybe 5% or more of upper tract cancers are due to Lynch. So we've all been focused on colon cancer, partly because of that silly old term that we originally used, HNPCC. But in fact, the urothelial cancers, we need to look at them as well. And this is my take on the 4 genes. And PMS2 actually Neil rarely makes mistakes, cross his finger behind back, but what he did say was that PMS2 was rare. Actually, it's very common. It is the most common variant in the population. Yes, they do rarely get cancers. That's right, absolutely true. But 1 in 700 people have a mutation in PMS2. And we're missing most of those in part because our sequencing technique's really rubbish at dealing with PMS2 because it's got lots of what are called pseudogenes. And so it confuses the computer. So I think there's a lot more of them. But as Neil did say correctly, the PMS2, he got that bit right. PMS2 is much less likely to cause cancer generally. It's a bit of it's the drummer, basically. I am a drummer, so I'm able to say that. But MSH2 and MLH1 are really important. So this is from the prospective Lynch syndrome database. Remember, this is prospective in the sense you only get onto this list if you've got a diagnosis and have started screening. But of course, it goes back now. We've been running it out for several years. We've got about 500 people of the 8,500 or so in here. And so these are really clean data in terms of working out what the risks are. These are not looking backwards at families that turned up at the clinic. This is looking forwards at people who've got the gene. And the blue columns here are the colorectal and the percentages up the side. So you can see, you all know this, MLH1, MSH2, a little more than 50% will get colon cancer and a little bit less in women. The orange columns there, the endometrial, sorry, actually it's gone wrong colour that. So the endometrial cancers in women, 44%. But the important thing for today is the urothelial cancers, the yellow ones. And so the yellow cancers there you can see are actually very common too. And you put them together, there are more urothelial cancers in MSH2 people than there are endometrial, because endometrials are only affecting women, obviously. So in fact, this is a really important group. Rakesh, you heard from last year, those of you were here, I think. And Rakesh is our professor of urology. And he and I got a grant which paid for Rebecca, looking here fresh before she had a child. And we set off to do a study in Newcastle. This is the other scary data. Remember, some of this is from the old days before we had some of the new treatments you've heard about today. But the 10-year survival for people who get these cancers, so endometrial is 93%. These are pretty good 10-year survivals for people turning up with cancer. Obviously, as a cancer survivor myself, I know that you see the other side of that equation. It doesn't look great. But of course, it is better. But the urothelials are 71%. So that's down at the bottom there. We're missing out on treating people with urothelial cancer because we're not looking for them because we haven't had a test to date. So how do we look for urothelial cancers? Well, cystoscopy is a bit intrusive. It is used in some places. I know Birmingham do cystoscopies, but you can all imagine it's not the most fun thing to have done, to have a small camera passed into your urinary tract. And yeah, your reaction there was, ooh, yeah, I don't want one of them. So we don't do them. Abdominal ultrasound, very poor at picking up the urothelial cancer. The ureter is the pipe down from your kidney to your bladder. It misses them all the time. Urine cytology misses most of them as well. We did a study back with the Danes, led by Tobias Mayhoy in 2008, and they missed most of the urothelial cancers using cytology. So, undeterred, the European Association of Urology recommended that everyone should have urinary cytology, urine analysis, and abdominal ultrasound on a regular basis, and went to great lengths to say how often you should have them. The people at the Mayo Clinic activated that. They looked at 204 people, 19 of them had hematuria, none of them had cancer, 5 of them got cancer, and they missed them all. So for the gynecologists in the room who aren't very good at maths, that's 0% sensitivity and 0% specificity. So it isn't a great way of spending NHS money. We're sort of kicking an open door, really. So we came up with this idea of using the test you've already heard a bit about, the MSI Plus test, and extracting DNA from postal samples. You've already had these introduced by Neil. And this is Christine, our senior technician, who is on the wrong end of this incoming flood, and Rachel, who developed the assay and applied it to the kidney. So you've already heard many times, but just very briefly for those who don't know, so it gives you a score, and we use 14 different markers. And unlike the one that's been used and was used for the guidance on endometrial cancer, for example, we use many more markers, but they're short markers so they can run through the high throughput sequences. The test that's been widely used and was used to generate the nice guidance on endometrial cancer used a thing called the Promega Oncomate, which are very big markers, and actually it's not a very good test. So this was some of the validation work we did, and you can see that the colon cancers that are stable are very clearly separate from the ones that are unstable. This was one that Promega said was unstable. We said it was stable, and so did the immunohistochemistry. So, in fact, we've got quite good evidence that the assay is more accurate. And even in endometrial, it's actually slightly more accurate than immunohistochemistry. This is Patricia, one of our master students who moved over to be a grade 6 tech and is now training as a scientist. And she tried this out, and Lizzie Sollers, one of our bioinformaticians in the Northeast and now with the Northwest, designed this beautiful piece of software. So this is what the people in the lab see. And the key thing you saw in that earlier cascade is that the MSI test is followed by BRAF testing and other things. So this puts it all into one test. And so basically this sample came out well up on the positives. It was BRAF positive, which means it's almost certainly a sporadic and it doesn't need germline testing. And it was good quality result. So that goes straight into the report to the MDT. And they're told this is one that doesn't need to be referred for Lynch syndrome. In the process of spending a couple of million quid from the NHS to make the assay better, we got it down to the point where it will now pick up DNA at a level of 0.1 nanogram per mil. So it's basically like a forensic test. And I had the thought that really it was so sensitive, it probably would work as a urine screening test. And so Adam from Guy's, and he's still here. Is he still here? No. So Adam had one of our CaPP3 patients present, Alan there, with a renal cancer. So we popped down and got a sample from him. We got his blood before and after in his urine. And these are the individual markers in our assay. And it's presented in a slightly different way here. These are what proportion of the markers were different, were variant alleles. And you can see there that if you look at the colored dots in the tumor, they're basically the same as the urine. So we're seeing tumor DNA in the urine. And if we just look at one of those, this is the LR52 marker, the red one. You can see that we had a predominantly single spike with a little bit of noise, which the computer ignores. And then it goes obviously very abnormal and then comes normal again when the kidney got taken out. So it worked. And I showed you this data last year for those of you who remember. And I also showed you about Ali, who was one of my patients from several years ago who had an MLH1 gene defect. She had been bleeding for 6 months. Her GP told her it was the change of life. And then a gynecologist reassured her that she had a fibroid and it was all fine. So she paid for another gynecologist to look at her. And he was going to reassure her, but we stepped in and got some urine samples and vaginal swab. And this is what it showed. And, clearly the tumor, the Streck sample and the CaPP sample and the swab were all clearly weirdly abnormal. So we got her in for an emergency pathology alert. Close your eyes if you don't like seeing pictures. I changed the color slightly so it's not quite so offensive. But she had her uterus removed and this was inside her uterus. There's the fibroid up there. And this was a high-grade endometrial cancer that required radiotherapy. But she's now, in fact, I told you last year, she just got married at the time of our last meeting. So basically, this was a near miss and clearly reassured us that this could pick up endometrial cancers as well. So I set off selling it to the urologists around the country at various meetings. And there's Bhavin and Arjun, who are my sidekicks in the urology department. And Richard Martin helps with the genetics. And Rebecca wrote to all of our MSH2 gene carriers in the region who were over 30 and under 75. There were 142 of them, 83 of them said they'd play. We were actually offering them a clinic appointment, but we then followed that up with just a simple postal urine sample. We also collected samples from every person presenting with the urothelial cancer of what any type coming through the clinic at that time. So this is what we found. Most of them were stable, both in the tumor and in the urine, but 2 of them were abnormal. And this was a man who was 72. He had lost MSH2 on IHC when he had his surgery. You could see his pre-op urine was sky high, and we germline tested him, and he had MSH6. And then this lady turned up with a transitional cell carcinoma in her ureter, and also she had a colorectal cancer, again, sky high in both the colon cancer, the tumor, and the urine. And it all went away, and germline testing showed that she had MSH2. So that was 2 Lynch patients, 2 new Lynch families out of 18 patients turning up and coming through the door. The most exciting results came from our 83 participants who had MSH2. All of them were asymptomatic when we recruited them, but one of them actually then developed hematuria and symptoms of bladder cancer, and he had surgery, and we got to him after the surgery, but his urine was still sky high. So they went back in, found that they'd missed some of the tumor, tried to get it all out, but realized they couldn't get it all out. So the second sample was still positive, and then it went back up again. I'm hoping he's going to get some immunotherapy. So that was very important because we would have obviously picked him up if he turned up soon enough, but also it showed that we were able to tell the surgeons if there were missing things. And that's so the surgeons are now really interested in this for monitoring the patients. The second case that turned up was a bit of a confusion. This lady was 75. She had a positive urine test that then went away of its own accord while we were waiting for her to be investigated. She had a scan, and the scan showed something very scary in her kidney, but it was actually called a Bosniak cyst, which are quite common in the population. And Andrew, our radiologist, managed to drag out an old picture that she'd had in 2019, and it was there as well. So this is probably a red herring, or it might be a bit like an adenoma or something that's just a little bit MSI high, but it hasn't actually gone bad. Difficult to know. The other strong possibility, though, from what you heard earlier on the immune treatment, is that she just killed it herself. It actually went away of its own accord. And this comes back to the earlier conversation about how often we do colonoscopies, because there's pretty good evidence that we think we're finding more cancers the more frequently you do scopes. And so some of these cancers probably do just go away. And so you're bound to get some sort of false positives that aren't really false positives. This gentleman had had a previous urinary tract cancer. He'd lost a kidney, and he was asymptomatic, and he had a 2-centimeter cancer in his other kidney. So they're going to try and get that out without taking away his kidney. Otherwise, he's going to end up on dialysis. But clearly, had he waited until he became symptomatic, he'd have lost his remaining kidney. This lady is great character, Carol. And I spoke to her, I went to see her in the ward, and I said, was this really asymptomatic? She had a 7.4 centimeter cancer in her kidney. And she said, well, I did get a twinge when I was cutting logs with a chainsaw. And I said, well, we'll call that asymptomatic. And so what was weird, though, was that the renal cell carcinoma was microsatellite stable, and that's not a urothelial cancer. However, when she had her surgery and took away that kidney and ureter, the signal disappeared. So either there was something else in there that the pathologist missed, which is unlikely because we were obviously looking hard. I think the most likely thing is that cancer had a microsatellite unstable clone, because once you've got cancer, things start going wrong. And so we're in the process of testing all the bits we've got to see if we can find the answer to that before we write the paper. This lady had COVID and was on ITU while we were investigating her. So we've literally just last week finally got her scoped, and she had 5 urothelial cancers in her kidney, which were completely asymptomatic. And then finally, in some ways, the most exciting was this young man of 47, completely asymptomatic, gene carrier, and he had a thing the size of your thumbnail in his ureter, and Arjun managed to destroy it, and the signal's gone away just with his endoscope. So we think we've actually cured him without major surgery. So that's a really high, it's actually almost scarily too many. But obviously, some of these might have gone away of their own accord, but they didn't look like they would. So this is Robotech, this is Lois. So we're now gearing up for a deluge of your urine. And the good news is our COVID lab, we built a COVID lab in the COVID crisis, and we did 8 million tests. And then the government said, shut it down. So I said, well, we'll just borrow that robot. Thank you very much. So we repurposed the robot, the TCAN robot, for doing our MSI assay on. So it will run 3 96-well plates at a time. So you basically set up all the stuff that on the telly, you always see people doing this. Well, instead of sitting with pipettes doing that, which is really boring, the machine does it overnight. So that will just allow us to take as many samples as we can get in. So that's basically the story. These are all the people who actually did all the work. I just draw attention in yellow at the top there. Donna, along with Christine, will be the 2 people. We've written a grant to fund them to be focused on this as soon as we finish with the CaPP sample collections and so on. And so we're ready, we're gearing up, and that will basically, with Lynch Syndrome UK, we'll be writing out to all of our CaPP participants and also the Lynch Syndrome UK folks. And you can sort of log on to RedCap, which is an online consent system. So you basically read about it. If you're happy to play, then you will log on to our system, and then we'll send out the postal urine samples to people. Obviously, you'll have to take time because we can only process initially about 20 a week. We'll probably focus on the MSH2 gene carriers first, and particularly the group that Neil was collecting, where we've got the potential of endometrial pickup as well as urothelial pickup. So in summary, that should say 83 now. 6 out of 83 people, 7%. We had a couple of asymptomatic urtox, and you know, basically we found some cancers. We had one that was an unexpected stable renal cell carcinoma, but the signal went away when we took it out. And then we had that one strange positive that went away of its own accord. So we had the 2 out of 18. So these are the 3 other bits. Neil's already talked to you about the Muse study, and so we're testing urines already from Edinburgh that Neil raised the funding for. Kevin's already got consent for your people coming through the bowel cancer screening program at St Mark's, so we can start testing them just as soon as we've got the paperwork in place. And then we hope to be able to gear up for self-referral through Lynch syndrome UK and the CaPP3 community from about May onwards. I've spoken to the chair of the ethics committee, and he's basically completely relaxed about this because it's clearly beneficial. It doesn't hurt giving a urine sample. You clearly have to give consent to give a urine sample. It's very hard to steal it from you without you noticing. And so basically it doesn't present any ethical problems. If we find a positive, as with the Grail test, if we find a positive, we'll immediately notify people and notify their own team. And we have a network of clinical cancer geneticists across England. At the moment, this is just in England, while we sort of work out what happens in the devolved administrations. But in England, we have a clinical geneticist who will be the point of contact if anybody has a positive. So you've got somebody to help you into the system. But essentially, if you've got MSI high DNA in your urine and you've got Lynch syndrome, you are a 2-week wait referral. And so we're not paying for that. We're just alerting the system to say this is someone who needs checking out. The other thing is that you saw from George's slide that it was a bit more noisy, and that's because we trained the computer to find MSI high in particular tumor types. And so we'll be retraining the system to the urothelial as we are for the sebaceous. But we're also thinking about putting in some of the markers. Sorry, this slide's got a bit amplified. But there's a bunch of other markers that will help us to pick up particularly bladder cancers, because obviously any of us can get a bladder cancer as we get later in life. And so it'd be nice to be able to pick up the ones that aren't due to Lynch, but are there. So we'll try to make it a more generally applicable assay for future use. And just to get the last R out of the audience, Rachel had twins last week. This is William and Sophia. So my research team is getting really big. Thank you for your attention.
Yeah, I think we're moving towards non-invasive surveillance and trying to avoid harm. And we have to think about what the downstream effects of any non-invasive tests are. So a positive fit, you could have a colonoscopy, positive urine test, you could have a cystoscopy and whatnot. And we have to learn from what happens downstream as well. But I think, yeah, we're moving towards people having somebody is called a suite of tests when they come, but that are non-invasive, and for which really there is something that we can really hang our hat on. And we want to also avoid overselling. I mean, this is really compelling data that you're producing for this assay.
And I think everyone will appreciate this is still a small sample. I would expect us not to pick up quite so many positives. We're a bit stunned by the number that turned up on this short approach. But we've got to convince the NHS in a stressed time that this has a significant clinical utility, a positive predictive value and a negative predictive value. Is it reassuring when it's negative? Is it really positive when it's positive? And only by doing will we find the answer to that. But also we're very keen on feedback from all of you on how best to do it. We suffered enormously from our packaging for CaPP3 and the little tablet packets that people moaned about forever. It wasn't my fault, just the regulations. But so, we want to know how people find it works for them. And the postal, the postal system seems to work pretty well, and Neil's already going to start rolling out to people who volunteered today, so that's great.